So thank you, Nikki and NCUK. Thank you for asking us to come and talk. The first thing I wanted to say is Mike and I aren't trying to be mysterious or unsociable, but we have had a whole host of IT issues, culminating in me ending up on our son's computer and I can't work his camera. So I'm afraid we're just going to be incognito, although I see quite a few familiar names on the group, so I'm sure some of you still remember what I look like, and I'm pretty sure Nikki's wanted to have a mute button for me for a long time. Anyway, without further ado, we're going to have a chat about carcinoid syndrome and carcinoid heart disease, and then we welcome any questions that you've got at the end. So I thought I'd make a start. As you probably all know, if you've had a neuroendocrine tumor for any period of time, you'll know that we use a whole host of different terms that tend to mean the same thing. So whether that be things from tumor or lesion or nodule or node or mass. But it also made me think when I was thinking about this, that any of you that have been diagnosed recently will probably just know of your condition as being a neuroendocrine tumor, and you might wonder where the term carcinoid ever came from in the first place. So I thought just out of a bit of Anarakish information, I'd start with a short history of carcinoid so you can see where the term has actually come from. So these tumors were actually first kind of described back in 1988, but in 1907, this German pathologist found some tumors at autopsy and decided that actually when you looked at them, and especially under a microscope, they looked like a cancer. But when you actually looked at how they'd behaved, they didn't seem to be like a cancer. They seemed to be a little bit more benign-like in their behavior. So he decided to call them carcinoid, which meant carcinoma-like. So carcinoma being another term for cancer. So he described them as cancer-like, so carcinoid. So that's where the original name came from. And these original tumors that he found he found them in the gut, so mainly in like the small intestine. And then a little bit later on in 1914, another couple of scientists found that when they were looking at these tumors, they found that there were some endocrine related properties for them. And in 53, it will become a bit more important when we talk about carcinoid syndrome. This chap called Lembeck decided or discovered that these cells produce serotonin. And in 54, another scientist came along and described these patients who had these carcinoid tumors and secondaries in the liver and noted that they were also having things like diarrhea, flushing, asthma type symptoms, and right-sided heart valve disease. And this is a constellation of symptoms that we now know as carcinoid syndrome. In 2000, the World Health Organization decided that we should really term these as neuroendocrine tumors because that's the type of tissue that they came out of. And so that's when the main change from calling them carcinoid tumors changed to neuroendocrine tumors. And historically, the term carcinoid tends to relate mainly to the small bowel tumors, and they're the tumors that give rise to the carcinoid syndrome. More recently, I think about 2018, who decided that we'd call them neuroendocrine neoplasms. And I'm not really sure that that's actually taken off anywhere outside of academic papers, to be honest. I think now there seems to be a bit more of a move to call them what they really are, which is neuroendocrine cancers. And that helps to get rid of that whole discussion about whether these are benign or malignant, and that could be a whole other topic, which I'm sure has been covered at some point in time. But that's where the term carcinoid actually comes from in the first place. So as many of you may actually experience for yourself or have heard about, there's this syndrome called carcinoid syndrome, and I touched on it briefly in the last slide. It's the most common hormonal syndrome that is related to neuroendocrine neoplasms, cancers, tumors, whichever term you want to use for them. What we know about these tumors is they secrete multiple types of chemicals, hormones and peptides and amines, which are kind of proteins. And it's a whole lot of these that give rise to a lot of the symptoms that come along with carcinoid syndrome. Although it's thought that serotonin is probably the most important of the substances that are produced that causes the symptoms. So the usual primary site is in the tumor in the intestines and mainly in the small bowel. Although there is a small group of patients with pancreatic, ovarian, or thymic tumors, or patients with these retroperitoneal lymph nodes, the ones that are right at the back of the abdomen, where the blood flow goes straight from the tumor into the main blood system and bypasses the liver, who can also have carcinoid syndrome. And then kind of greater than 87% patients tend to have liver metastases before they necessarily have the symptoms of carcinoid syndrome. Although, as you'll all know, you're all highly individual, which makes you all a fascinating group of patients to look after, because all of you are very individual, very different, and not always following the same path. So if we think about how does carcinoid syndrome actually occur? So if we think about, you've got a tumor here in the small bowel that's excreting some of those substances. We'll just talk about serotonin mainly because it's shorter. So the tumor secretes some serotonin, and then through this multiple blood supply here, it feeds up into the liver. And pretty much all of the blood in the gut will go to the liver in the first place, because it's carrying all of those products of digestion, all those building blocks, and the liver stores these and turns them into other usable substances. So it's a bit of a warehousing and manufacturing depot. So all the blood goes to the gut. It's also like a 5-star all-inclusive resort if you're a tumor cell. So that's why neuroendocrine tumors, along with many others, like to set up home in the liver if they're going anywhere else. Now, in the first instance, if you've just got the small bowel tumor, the liver will actually deactivate most of those substances. And so you may not have symptoms, especially in the early stages. And if you've got a small tumor that isn't secreting a lot, because the liver deals with everything. But once you've started to get liver metastases, these liver metastases, because they're children of the primary tumor, of the parent tumor here, they also will secrete these hormones and various substances. Now, the problem with these is they drain out into the main blood supply again, but they don't go through the liver. They've come from the liver, but they have to do a whole lap of the body before they come back to the liver, where they can be deactivated. And that's why you start to get problems. It's because you've got those high levels of especially serotonin circulating that's causing all the problems that you can have. And so that's how they kind of occur. And that's why we tend to see the symptoms mainly once the liver has become involved. Symptoms which many of you may be quite familiar with. So flushing is really common. It can occur in 90% of patients. Patients or people, you're not patients, tonight you're people. People may not tend to notice that they're flushing, but often somebody in their family or shares their household will. And flushing can tend to be face and or neck, and can be anything from mild to people who are kind of plum-like in colour. And the flushing can come on at a variety of times or without any rhyme or reason at all. Diarrhea is also really common. Tends to happen in about 60 to 80% of patients. And I'm sure any of you that have had carcinoid syndrome and all of that diarrhea could have done with a toilet roll about this size at some point in time before we get symptoms under control. Wheezing can occur as well, but it's quite rare, and it's only in about 15% of cases. So these are the typical symptoms that go along with carcinoid syndrome. So if we're thinking about how do we diagnose it, how do we know that someone's got carcinoid syndrome, we can look at identifying symptoms. So we're looking for the flushing and the diarrhea and maybe the wheezing. But as I'm sure a lot of you knew, it is important to look for other causes. Although if you've got a neuroendocrine tumor in the small bowel, it's almost certainly going to be the cause of your carcinoid syndrome. But I'm sure many of you have been to your GP for years on end with all sorts of symptoms and been treated for all of the other different causes for these issues. So whether it be irritable bowel or menopause. But there are other reasons why patients with neuroendocrine tumors can get things like diarrhea, and that's looking at things like previous surgeries and operations, and also analogs. So it's important for us to think about the other causes of diarrhea in a group of people that have neuroendocrine tumors, rather than just rushing to the conclusion that it must be carcinoid syndrome. We can do some blood tests. I mean, there is chromogranin A, but chromogranin A is only helpful when it's helpful. And that means that not everybody will have a raised chromogranin A. It's not specific for carcinoid syndrome. If it is elevated in a patient with neuroendocrine tumors, then it can be useful for looking to see whether it's going up or down, but it's not particularly helpful with carcinoid syndrome. But the test that probably is the most helpful is urinary 5-HIAA. And I'm not going to even attempt to tell you what the 5-HIAA stands for, because I can't pronounce that. But the basics of what it is it's the metabolism or the metabolite of serotonin. So when the excess serotonin that the tumor produces is broken down, what you find in the urine is 5-HIAA. And we can pick that up either through a 24-hour urine collection, is common in most places. And some places, like at King's, we can do random urine specimens. And there can also be false positives that are due to some foods. So things like banana, pineapple, plum, kiwi, avocado, eggplant. I meant to change that to aubergine, pecans and walnuts. What we tend to do at King's is not ask people to follow a restrictive diet, because we tend to look at a trend. And people's diet doesn't massively change over time. So we just take things as a trend rather than just a one-off reading. Okay, so treatment. What would we do for carcinoid syndrome? Aims of treatment is to look at controlling or reducing the tumor burden. So the less tumor there is, the less it can produce serotonin. So that's one of the things that we'll do. We also want to prevent other complications such as carcinoid heart disease, that can come as a result of having carcinoid syndrome. And we want to improve nutritional status and quality of life, because carcinoid syndrome, with all the diarrhea and everything, can have a huge impact on quality of life and nutritional status. So we want to try and do those. The main aim of treatment would be surgery when it's possible. But for many patients, especially if they've got liver metastases that are spread throughout the liver, then surgery isn't something that we can do. And then we're looking at medical ways of managing disease. So I'm sure many of you have been through somatostatin analogs. Some of you might have had PRRT, also known as lutetium treatment or Lutathera. And if you talk to people that are in other countries than the UK, or especially England, you may hear about treatments such as SERT and talotrostat, which unfortunately are not really available here currently. But these can also help to control, SERT can help to reduce tumors, and talotrostat helps to bind to serotonin and stop production of that. So that will be our aim. We want to try and reduce the amount of hormones that are being secreted out of these tumors. There's been a couple of really important papers. They're a little bit older now, so they come from 2009 and 2014. And what they showed is that as well as somatostatin analog injections controlling hormone output, they were also very useful at slowing down the growth of tumors. So these are now really widely used. And actually, it's the 10-year anniversary of the trial, Clarinet, that looked at lanreotide. So they've been around for a long time, and they are still really useful. But this was a really helpful to know that it wasn't just symptoms they controlled, it was also tumor growth as well. So if we think about one of the most serious consequences of carcinoid syndrome, other than the diarrhea and the malnutrition, the one that really has an impact on life expectancy is the development of carcinoid heart disease. So it can affect about 1.1 in 5 patients with carcinoid syndrome. And again, it's thought to be related to the abnormally raised levels of peptides and hormones in the blood, particularly the serotonin. Now, what happens is, you remember I said that the tumors in the liver will secrete the hormones, and then they have to do a whole lap before they get back to the liver to be deactivated. Well, one of the first structures that they actually hit is the right-sided heart valves, and they can have an action on those that causes thickening, and they become quite stiff. And then they don't really work, and then they become really leaky. And that's called tricuspid regurgitation. Mike's going to talk more about heart valves and normal heart function and things in a minute. So it's mainly the right-sided valves that are affected. The left-sided valves are less affected because some of the hormones are broken down in the lungs. So unless you've got a hole in the heart, it tends to not affect the left valves so much. And symptoms of carcinoid heart disease can include things like breathlessness, fatigue, swelling, weight loss, or weight gain if someone's suddenly holding on to a lot of fluid and got really edematous legs. But for a long time, carcinoid heart disease might be occurring without any symptoms at all, just like your original tumor would like to go undetected for quite some period of time. So I'm going to hand over to Mike now because he's my heart specialist and he can go through some slides with you now.
Right, as Wendy said, the left side of the heart and the right side of the heart are completely separate, and the two don't communicate with each other unless there's some sort of defect. You might think of it like a semi-detached house. It's two separate entities. And the reason why you have the problems that you have with the carcinoid syndrome is because the blood is coming straight from the liver to the right side. Once it goes from the heart, it goes to the lungs, and there is some clearing of things before it comes back to the heart on the left side. So basically, you've got the blood coming in from the whole body into the top chamber, which is the right atrium. It then goes through the tricuspid valve, which is one of the valves that ends up with the problem when you have carcinoid heart syndrome. It then goes from the right ventricle through the pulmonary valve onto the lungs. And then it comes back on the left-hand side through the mitral valve and then through the aortic valve to the whole body. Okay, so what we've got here is some images just showing you how the flow of the heart, how it works, where the blood is coming through the right side and then going out to the lungs. And then with the regurgitation, what happens is when that right ventricle contracts to push the blood out through the pulmonary valve to go to the lungs, because the valve doesn't close properly, it's a leaky valve because it should be a one-way valve. What happens is blood gets pushed back up through the right atrium and then out into the venous system, which then causes that congestion in the lungs. I don't know if anybody, if any of you have carcinoid heart disease or if you've ever had surgery for it, but the things that you experience as a result are the things like the shortness of breath with only a little bit of exertion, and the swelling, particularly in your feet and ankles. Just got some pictures here of what the normal tricuspid valve would look like when it's closed and open. When it's diseased, when it's closed, it remains open. And that's why you've got the flow going back through the valve when it, essentially it's plumbing. Right. The way it's initially picked up quite often is a blood test, the NT-proBNP, which is just a marker of heart that's not happy. And then an echocardiogram is done, and that will show up that there is a leaking valve. If you're listening with a stethoscope, you will definitely hear what we call a murmur. And all a murmur is an abnormal heart sound, which is because of the valves not opening, closing properly. Quite often, this is picked up quite late with patients with carcinoid syndrome. We actually have a patient at the moment who's probably had neuroendocrine tumor for about 9 years, but only in the last 3 months has it actually been picked up, and very quickly it's been picked up that she also has a valve problem. Right, so treating it before surgery, your net team would be trying to reduce the hormone levels, and if the When you get anything from severe regurgitation onwards, you do need to have surgery, because this is not something that will go away on its own. And there is no medical management that's going to improve the situation. It will just continue to deteriorate. Just got some pictures of types of valves that you can get. Three of them are mechanical valves, which means that you need to be on warfarin for them. And then we've got the bioprosthetic or tissue valve, which is what is used. We don't use the mechanical valves because patients need to be on warfarin, whereas with bioprosthetic valve, we don't need that. Yeah, the pros are no need for warfarin. The cons are it doesn't last as long as the mechanical valve. The mechanical valve will normally outlast you, but you do have to be on the warfarin. It's also susceptible to damage from the carcinoid disease. It's difficult to actually give you a lifespan of the valve, but generally you're looking at an average of 10 to 12 years. So some people will, it will last much longer. Some people, it won't last quite as long. Right, preparation for surgery. Exercise and looking after yourself is key. And that doesn't mean you've got to go for a run. It's probably a good idea not to go for a run. You could put a lot of strain on your heart. You could have a heart attack as well as having the valve problem. But you can do simple things like sitting in a chair and doing some exercises. You'll see a lot of stuff that can be, if you, I don't know if anybody watches the program on BBC One After Breakfast, where they have some exercises people, and you'll see people, one of the presenters will be sitting in a chair and others will actually be doing the dancing, kind of like Strictly stuff. But also, if you're able to go for a walk every day and eat a healthy diet, it's really important. Right. So how do we do the operation? Well, we cut through the breastbone. It's called the sternotomy. And we have to cut through the entire bone for us to be able to actually access the heart and have a good look inside. You get put onto the heart-lung machine, which is known as cardiopulmonary bypass. And we go in and we replace the tricuspid valve. At the same time, we always look at the pulmonary valve, which is a valve that takes the blood from the heart to the lungs, because very often that is damaged. And if it is damaged, it's important that we replace that, because otherwise you will come back to us within about a year or two with a problem, and we'll then have to replace that valve as well. But we do always inspect it, and we will only replace it if it needs replacing. We put in some pacemaker wires, but they're only temporary. The little wires that are attached to the heart and come out through the skin, because when we do the operation, the conduction system for the heart, which is like the heart's pacemaker, the natural pacemaker, can be disturbed, and so we might need to increase your heart rate after the operation, just so that you've got a good blood pressure. So those are placed and you're attached to this temporary pacemaker. We also put chest drains in, because there's going to be a collection of fluid, mainly blood, that will need to come out over the next 24 to 48 hours. When we close up, we use some wires. It's normally like stainless steel wires to close the chest up. Bone takes 3 months to heal, so we need something to keep it in place and stable. Once the wires are in, unless there's a problem with the wires, we never take them out, because it means going in for another operation, and there's always risks associated with operations and general anesthesia. Right. Your stay is going to depend on how well you were before the operation and how well you tolerate the operation. Generally, you're looking at about 10 days. And um, at King's, we admit our patients the day before and the operation. And depending on how they're doing, will influence how soon after the surgery they go home. Um, we're looking at several factors, but probably one of the main factors is that we need to make sure that all the excess fluid, we've got rid of as much of it as possible before you send you home. You come out to theatre and you go to the cardiac recovery unit or cardiac intensive care, where we attach you to a ventilator. We don't wake our patients up. We keep them anesthetized until we're happy that everything is going well and there's no bleeding and no need to go back to theaters. So, and that can happen either late afternoon if you were done in the morning or sometime during the night. So when you first wake up, you can't speak because you've got this tube going down into your lungs. But the moment we take that out, you're able to speak. You feel incredibly thirsty. But we do give our patients intravenous fluids to make sure that they're adequately hydrated. So along with the chest drains, and the temporary pacing wise, you'll have a urine catheter in because it's really important that we can monitor how well your kidneys are working after the surgery and that you've got a good urine output. We have lines going into your neck so that we can give you the intravenous fluids, but as well as that, any medication, intravenous medication that you might need. Very often patients come out of theatre after heart surgery and they have a low blood pressure. So we need to give things like noradrenaline to push the blood pressure up. What else is there? Yeah, that's pretty much it. Oh, you'll have an arterial line, which we can take blood directly from you without sticking a needle in you. So for the first 2 to 3 days, we don't need to stick needles in you, which is always very nice. And we can get the blood from the lines. The day after the operation, we will the nurses get you out of bed really early and sit you out in a chair. And it's not as simple as hopping in and out of bed like you do now. It takes the assistance of 1 or 2 people to actually get you out of bed because you're attached to various machines and you've got all of these tubes and lines going into you. Everything is hard work. So just do be aware of that. But we are there to help. You're going to feel incredibly tired, which is totally normal. I generally tell my patients that they're going to be hit. It feels like they've been hit by a freight train. And all they want to do is sleep all the time. That's totally normal. You'll have a dressing on as well, which we don't normally take off until the 4th day after the operation, unless there's excess oozing from the actual wound. And the reason for that is every time you go in there, you're exposing increasing the risk of an infection of the wound. So we try to leave it alone until it heals more. As the days go by, we take the drains out. The chest drains normally come out on the day after the operation or the 2nd day after the operation, depending on how much fluid is coming out of them. The urine catheter we take out on the 2nd day after the operation, and the line in your wrist we'll take out the 2nd day after the operation. The lines in your neck we take out on the 2nd or 3rd day, just depending on how things are going. But any time from the 2nd day after the operation, we'll actually have you walking, and we encourage you to walk because when we put you on when you have the operation, you go onto the heart-lung machine. We stop the heart from beating completely, and we collapse the lungs. So the machine is doing the work of the heart and the lungs, and in order to reinflate your lungs, we need you to be upright as much as possible and not in bed, but also we get you walking because you naturally take a deeper breath when you're walking. We also give our patients a little contraption called an incentive spirometer, which means that they can focus on doing deep breathing every hour. And rather than just taking breaths in, it gives them something to focus on and work on. Right. When you go home, you will be contacted by your local cardiac rehabilitation team for formal rehabilitation. But before that happens, what we encourage our patients to do is to go for a walk every day. And every day we say to them, go a little bit further. And it's up to them to decide whether they do that based on time or distance. And we don't tell them how much they must do on their first walk. Basically, we encourage them to do it based on the walking that they've done in hospital before they go home. You're going to need a lot of rest. So having a morning nap and an afternoon nap and going to bed early and waking up late are all totally acceptable. Through all of this, your body is working incredibly hard to recover from this massive insult. So it's using up a huge amount of energy, and all of that energy that it uses up calories. So although you may not have a good appetite after heart surgery, we do encourage you to eat. And if you're not able to eat that much, instead of eating 3 meals a day, eat 5, 6, 7, 8, 10 times a day. Just have small amounts at a time. Nausea and vomiting are quite common after heart surgery, and it can take a while to get that appetite back. The other thing patients often complain about is the fact that they lose their sense of taste. Everything tastes like cardboard, so they have no desire to eat. Yeah, it could just be hospital food. Right. Because we cut through this chest, the breastbone, and it takes 3 months to heal, you have to really be careful in your activities. You've got to be careful not only with lifting, but also pushing, pulling, and carrying. We say to patients, if it's anything more than a bag of sugar, don't lift it. You can make yourself a cup of tea, things like that, but no heavy lifting, no vacuuming, forget about the ironing, no bed making, or any of that type of thing. You've got to. The problem is if you start doing things too soon, the bone doesn't heal properly, and you get movement, and then you just end up with persistent problems. So you've got to just let it heal. Most of the healing will take place in the first 6 weeks, so you end up with a lot of stability. And by the time you get to 6 weeks after surgery, you're feeling quite well. But you do need to give yourself 3 months to recover. In general, all of our patients take 3 months to recover from heart surgery. Added to that, you have carcinoid disease, so you've got an additional layer. So it might take a little bit longer for you to recover. As well as the housework, don't go doing gardening. If you want to do some light pruning, you can do something like that, but don't go out there with a spade or a lawnmower. You're not allowed to drive for 6 weeks, and that's not just us, that's the DVLA, and your insurance won't cover you. You don't need to notify the DVLA or let your insurance company know that you've had the operation, but you just need to bear in mind that you can't drive for that 6 weeks. Right. Oh, one more thing. Your teeth. Before we operate, we get our patients to see a dentist and make sure they've got dental clearance. And then after surgery, you need to see a dentist on a regular basis, preferably every 6 months. And the reason for this is there is a condition where you can get an infection on heart valves, and that can happen to any of us at any time. But if it's your native valve, you can have antibiotics, and hopefully the antibiotics will sort it out. Sometimes you need to have valve surgery because of this infection on the heart valves. If you have an artificial valve in, there's probably a 98 to 100% chance that you will then require surgery. And the problem is that second time round, the risks are much higher. And so it's more about take care of yourself so that we don't end up with the risk of having to go in and do the second operation.